Good morning. I'm Nitish Aggarwal, and I'm going to present on association of diastolic shock index and pulse pressure index with mortality in septic shock patients in the ICU. My mentors are Paul Hare and Ranjit Deshpande. I'm an anesthesiology resident at Yale University, and I do not have any disclosures to present. So background-wise, septic shock comprises of circulatory and metabolic abnormalities and has a mortality rate above 30 to 50% worldwide. The purpose of this project was to improve the outcomes of the septic shock patients. We need predictive mortality of the hemodynamic parameters. So conventionally, we use heart rate, MAP, SOFA scores. Even Apache 2 uses heart rate and MAP. But we wanted to use diastolic shock index and pulse pressure index and to see if there's an association. In terms of the study's design, this is a retrospective study with 70,000 ICU patients admitted to Beth Israel Deaconess Hospital over the 12 years. The patients were admitted for severe sepsis with septic shock, yielding a total of 2,500 patients. And so for each patient, the exact time of the vasopressor start was determined. And that allowed us to ascertain the parameters such as heart rate, systolic, diastolic, and mean arterial pressures at that time, and then subsequently over the next 72 hours. In terms of the demographics, the mortality rate in the study was 30% for the septic shock patients in the ICU. 45% of the patients were female. And then the bottom table has a breakdown of the different ICU units with the blue arrow showing the mortality rate of 32% in non-survivors and 28% mortality rate in SICU. This is a graph that's showing a time course of the diastolic shock index, which is on the Y variable. The X variable is the time, so VP as denoted by the black arrow, that is the time when the vasopressor was started, so time or T equals 0. And then it has the subsequent time over the next 72 hours. The blue curve is the survivors, the red is the non-survivors. And as you can see, there is a gap between the survivors and non-survivors throughout the 72 hours. This is a similar time course graph of the pulse pressure index. And as you can see by the y-axis, the numbers, at least the index numbers, are pretty insignificant clinically at least, and the graphs are almost superimposed. This graph is looking at rate pressure product, which is systolic blood pressure times the heart rate. And this has been shown to be a predictor of worsening clinical outcomes in septic shock. So as you can see, between the time equals 0 when the vasopressor was started and the time 12 to 24 hours, there is a gap, but otherwise there isn't much difference between the survivor and the non-survivors. This is a t-test between the survivors and non-survivors. And as you can see by the red arrow or the diastolic shock index, the p-value is less than 0.001. But for the other indices like pulse pressure index and the rate pressure product, the p-value is not significant. This is looking at a logistic regression for survivor. And as you can see with the blue arrow, the diastolic shock index had the maximal effect. In terms of the estimates, all the other indices and then the type of ICU area or the gender were not significant. This is a different way of looking at or stratifying the risk of mortality based on parameters. And so this decision tree, the way to read it is looking at the green arrow. So all the patients where vasopressor was started, the mortality rate was 33%. If the diastolic shock index was more than 1.77, as evidenced with the first blue arrow, then the mortality rate jumps to 43%, the first red arrow. If the diastolic shock index was more than 2.6, that mortality rate is almost 60%, so double of where we started. In conclusion, diastolic shock index is a predictor for mortality and stratifying severity of septic shock patients in ICU. It's a superior index compared to rate pressure product at the time of vasopressor initiation. Physiologically, DSI reflects subendocardial perfusion. And so increase in heart rate will decrease that subendocardial perfusion time. Diastolic blood pressure is already evident in the coronary perfusion pressure. So DSI is just amplifying both the heart rate and the diastolic blood pressure. On the other hand, pulse pressure index in this study was not significant for a predictor for mortality. And lastly, possible intervention of beta blockade, at least the timing, can be based on diastolic shock index. Thank you.
Thank you all for being here. Today, I'll be talking about integrating single-cell and plasma proteomics in order to predict surgical site complications. My name is Amy. I'm a fourth-year med student at UC Davis, and I'm presenting my research with the Godelier Lab at Stanford School of Medicine. I have no financial disclosures. Complications occur approximately 1 in 5 surgeries. That means there are approximately 22 million complications, and of that, 2.2 million are surgical site complications. That translates to prolonged personal suffering and significant socioeconomic burdens. However, a patient's postoperative recovery trajectory is complex, and the current surgical risk calculator, NISCIP, predicts surgical site complications with an AUC of 0.7 or less. As such, perhaps we can integrate biological parameters that drive the pathogenesis of surgical site complications in order to increase risk prediction accuracy and improve patient care in the long run. The immune response to trauma is very well orchestrated and involves virtually all branches of the immune system and engages all immune cells. Therefore, it's important to be able to study the immune system at a single cell level and understand the function and role these cells play in the development of adverse outcomes. Luckily, this type of high-resolution study is now possible with mass cytometry. Using that, we can identify the major innate and adaptive immune cell subsets and quantify their abundance. We can then look at the function of each of these immune cell populations, such as their endogenous activity or how they respond to cytokines. Together, we can see how the immune system responds to immunological triggers, such as surgical trauma. We can take this technology and apply it to improve predictive performance. We hypothesize that single-cell and plasma proteomic elements can accurately identify patients who will develop a surgical site complication. We enrolled 41 patients in this study, and 11 patients developed a surgical site complication as defined. Blood samples were collected prior to surgery as the baseline sample and on postoperative day 1. The whole blood samples were analyzed using mass cytometry, while in parallel, the plasma concentrations of 272 proteins were quantified using the Olink platform. So mass cytometry produces a high-dimensional data set with very complex and interrelated processes that require advanced machine learning methods. In simple terms, we created elastic net models for each of the 9 data layers, and then we integrated them using a stack generalization method to yield the final predictive model, which was able to classify patients with a high accuracy, an AUC of 0.86. Delving into the biology a little bit more, some pro-inflammatory proteins were elevated in patients who develop a surgical site complication, such as STREM1 and LIF. Other proteins, such as EIF5A and KRT19, were decreased, which is suggestive of impaired healing. Some of the immune features that were picked up included the STAT3 pathway, which was exacerbated in the complications cohort, suggesting activation of a canonical pro-inflammatory pathway. However, there was also enhanced activation of counter-regulatory immune cell subsets, such as these MDSCs, as well as regulatory T cells that suggest that unchecked systemic activation of these cells may also contribute to the development of a surgical site complication. So in summary, the complex interplay between pro-inflammatory and immunosuppressive cellular mechanisms after surgery differ between patients with and without a surgical site complication. This difference is detectable as early as 1 day after surgery and is harmonious with our current theories on surgical site complication risk factors. However, we had these baseline samples, and we wanted to ask the question, can we predict if a patient will have a surgical site complication before surgery? And the answer is yes. So we applied the same analysis algorithm to the baseline samples collected before surgery, and the resulting model was able to accurately differentiate the 2 patients with an AUC of 0.82. Our latest model, which integrates parameters from the ACS risk calculator, improves this performance to an AUC of 0.94. This allows for promising interventions prior to surgery, such as prehabilitation. So in our current clinical trial, patients are recruited and enrolled in a rigorous 3 to 6 week rehabilitation program in which their fitness, nutrition, mindfulness, and cognition are optimized. Preliminary data has shown improvement in some of the surgical outcomes. Finally, I would just like to thank the amazing team that I had the opportunity to work with and that made this study happen. And thank you all so much for listening.
Hi, everyone. The title of my abstract is Electroencephalographic Features Associated with Seizure Risk and Outcome Following Antifibrinolytic Administration for Cardiothoracic Surgery. I have no disclosures to report. So first, to give a bit of background on our study, TXA and the less potent ACA are commonly used antifibrinolytic agents during surgery. They were first shown to decrease the risk of hemorrhage and mortality in trauma settings and have since been employed in a variety of surgical settings to reduce the need for transfusion. However, when employed in elective surgical settings, meta-analyses have not consistently demonstrated a reduction in blood loss or transfusion requirements with AF administration. In addition to thromboembolic complications, recent large human trials studying TXA in cardiac surgery have shown an association with postoperative seizures. However, these findings have also not been corroborated in meta-analyses. This unclear relationship may be partially because seizure is not a consistent secondary outcome in many studies, and when seizure is reported, it's largely based on the clinical presentation and not electrographic findings. In vivo and in vitro data from animal studies point to a potential mechanism for cortical hyperexcitability, as TXA and ACA can antagonize both GABA and glycine receptors, thereby decreasing inhibitory neurotransmission. In contrast, little is known about the effect of ACA on seizure risk. ACA is about 8 times less potent than TXA and is widely used in CT surgery as a safer alternative in terms of thromboembolic risk. However, the potential association between ACA and seizure risk is not well studied. This knowledge gap is underscored in CT surgery patients who are at a high seizure risk from neurological complications. Thus, we hypothesized that ACA administration may confer cortical hyperexcitability and seizure risk, and we further predicted that in post-surgical CT-ICU patients, we would find an association between ACA and seizure activity on CEEG monitoring. We undertook a retrospective analysis of EEG findings of patients receiving CEEG monitoring in our hospital CT-ICU for a 5-year period. We limited our analysis to CEEG monitoring less than 7 days from surgery to account for washout effects of AF administration. Of the patients who underwent CEEG monitoring in the CT-ICU, 83 met these inclusion criteria. 41 were given ACA. Within the non-AF group, 21 underwent surgery prior to admission to the CT-ICU, and 21 did not receive surgery prior to their CT-ICU admission. Here you can see with a bit more detail the makeup of our cohort and the makeup of how they stratified across that 7-day period. The light red bars represent subjects with ACA, gray surgical subjects who did not receive AF, and black subjects who did not undergo surgery. You will see in patients that receive ACA that they mostly received monitoring within 1 day after surgery, which is consistent with the half-life of ACA. In this first table, you can see the baseline characteristics of our cohort. In the first column, you can see the data for our total cohort, the second for those with no antifibrinolytics, and the third for our ACA group. There were no significant differences in demographics between the ACA and the non-AF group, but you can see that ACA administration is significantly associated with cardiac surgery, and that no AF is strongly associated with non-cardiac surgery. This reflects standard perioperative antifibrinolytic administration practices. Moreover, the most common reason for CEEG order was a witnessed event suspicious for a seizure, something like convulsion, twitching, or shaking, etc. Now, when we took a look at the CEEG specifics, we did find a significant association between electrographic seizure and ACA administration. Also, among those 16 subjects with seizure across all groups, the majority were subclinical and not associated with motor activity. Moreover, ACA showed a strong association with generalized seizures and associated markers of cortical hyperexcitability. We also took a look at the relationship between ACA dose and electrographic seizures and markers of cortical hyperexcitability. In this figure, the dots represent individual patients with weight-normalized ACA dosing. And we did see a trend toward electrographic seizure and markers of cortical hyperexcitability with increasing ACA dose, though it was not significant, with p-values of 0.07 and 0.1 respectively. Finally, in this table, we compared our subjects who had an electrographic seizure on EEG monitoring with those that did not exhibit an electrographic seizure. We found that having a seizure was strongly associated with advanced age, cardiothoracic surgery, use of cardiopulmonary bypass, having a witnessed event suspicious for a seizure, presence of an acute neurologic injury, presence of epileptiform and periodic discharges on EEG, specifically sporadic discharges. In summary, patients receiving ACA, known to be less potent for antifibrinolysis than TXA, may still be vulnerable to hyperexcitable cortical states, potentially warranting a lower threshold for CEEG monitoring. We found an increased incidence of electrographic seizure and markers of cortical hyperexcitability in patients receiving ACA, and a trend towards seizure and markers of cortical excitability with increasing ACA dose. However, the retrospective and exploratory nature of the study did posit some limitations, including a lack of control group, a small sample size, selection bias, as most patients undergoing CEEG monitoring had a witnessed clinical event suspicious for a seizure. Moreover, our small sample size did not allow us to control for confounders, such as cardiopulmonary bypass, in multivariable analyses. Future prospective studies should be designed to more fully elucidate the relationship of ACA administration and hyperexcitable cortical states. Thank you.
Hello, everyone. My name is Caywin. I'm a third-year medical student at the Carle Illinois College of Medicine. And on behalf of my colleague, it's my pleasure and privilege to present at SOCCA 2022 on our research, Gender and Racial Representation in Anesthesiology. I have no disclosures to make. So to begin, I would like to share an overview of the healthcare diversity in the US. Diversity can be defined and measured in different ways, but race and gender tend to be the most obvious ones. While female and minority physicians are still underrepresented, their numbers have been steadily improving over the past several decades. In comparison, anesthesiology as a field appears to under-index in both metrics. While the goal here is not to gain 100% parity, it is certainly helpful to identify where diversity efforts can be best targeted for the greatest impact. So the goal of this study is to analyze the race and gender distribution of anesthesiologists and the characteristics of the places and communities that they serve on a national scale. So to do this, we combined public data sources to build a database of 1,307 counties where an anesthesiologist participates in the Medicare Quality Payment Program. 71 variables were tracked for each county, including the quality scores and the demographics of the anesthesiologists, as well as the socioeconomic makeup of each county of practice. And then a diversity index was created for each county that represents the odds of finding 2 anesthesiologists at random to be of the same race and gender. This variable is scaled from 0 to 100. And then using GeoDA, which is a geospatial analysis software, we could then categorize diversity hotspots and cold spots into 4 groups using the Moran's I method. So just to briefly elaborate, Moran's I is a spatial autocorrelation approach to visualize statistically significant clusters for a given measure, which is diversity index for our case. The null hypothesis assumes random distribution of diversity across all the counties. Then a county is generated if both a county and its neighbors are statistically different from the national average. There are 4 types of clusters as pictured here. The first is high or low represents a county's diversity, and the second represents the average of its neighboring counties. And to extend the geologic analogy, high highs are like plateaus, high lows are like pointy mountains, low lows are like the Grand Canyon, and the low highs are like craters, such as Diamond Head in Honolulu. With these 4 types of clusters, we can then conduct a ANOVA analysis to compare the 71 variables we have in the database across them. Now for the results, here is the distribution of diversity clusters across the US. Overall, hotspots are predominantly located in the Mid-Atlantic, Pacific Southwest, Florida, Greater Houston, and Greater Chicago area, whereas cold spots were in the Rocky Mountain West, Nebraska, Deep South, and in addition, this map also identifies the low-high craters, which tend to be rural counties flanking the hotspots, as well as the high-low mountaintops, which are metropolitan counties interspersed within the cold spots. Notably, the average anesthesiologist MIPS score, which is a Medicare measure for physician quality, was found to have no significant difference between these clusters. However, what does appear to be different across these clusters, maybe not surprisingly, are the demographic makeup of the counties. The low-high craters share similar economic profiles with the high-high plateaus, but they have more white and English-speaking population at lower density. On the other hand, the high-low mountain peaks are similar to low-low canyons economically, but have a more diverse and denser population. So to build upon this study, we plan to create a more refined weighted diversity index to measure the diversity of a county's anesthesiologists against the county's overall population. So this could provide a more accurate comparison between urban and rural areas. We would also like to explore the relationship between diversity and potential causal factors, such as mentorship or workplace atmosphere. As for the next steps, our research can help to inform strategic actions in each type of clusters, with the ultimate goal to ensure that our physicians are equipped to provide quality care in our multicultural society. And I would like to thank my colleague for their collaboration in this work. And thank you for listening.
Hello, everyone. My name is Abid Fazal. Thank you for joining me. Today, I'll be talking about soluble Siglec-9 as a biomarker for acute lung injury. I am a critical care medicine and cardiothoracic anesthesia fellow at Stanford University, and I have no financial conflicts of interest to disclose. Beginning with a brief background, acute respiratory distress syndrome, as we all know, is a significant problem in medicine. It accounts for roughly 10% of ICU admissions and 30% of ICU mortality. As such, being able to recognize it in a timely fashion is very important, but ARDS is a diagnosis of exclusion. It lacks any definitive diagnostic test and is therefore very difficult to recognize. So it unfortunately goes under-recognized and under-treated. And while there is much that we have to learn about ARDS, one of the things that we do know is that neutrophil activation is a critical early step in ARDS pathogenesis. Siglec-9, which stands for sialic acid binding immunoglobulin type lectin-9, is a myeloid checkpoint inhibitor found primarily on the surface of neutrophils, but also other leukocytes such as monocytes and natural killer cells. And in its membrane-bound form, Siglec-9 binds sialic acid-containing glycans and has downstream anti-inflammatory effects. In its plasma-soluble form, or soluble Siglec-9, we see pro-inflammatory effects thought to be secondary to competitive inhibition of ligand binding to the membrane-bound Siglec-9. Soluble Siglec-9 has been found in higher levels in patients with COPD and lung injury, and therefore can serve as a potential biomarker for acute lung injury and then further development into ARDS. That leads us to our study, the purpose of which was to determine how well plasma soluble Siglec-9 levels correlate with disease progression and severity in ARDS. To accomplish this, we obtained plasma samples from participants of the LIPS-A trial, or the lung injury prevention study with aspirin. This was a randomized controlled trial looking at whether aspirin could prevent ARDS in patients who were deemed to be at high risk of developing ARDS using the lung injury prediction score. We retrospectively analyzed these samples with a single blinded operator performing our soluble Siglec-9 assays using a fully automated ELISA system. We then looked at the odds of experiencing one of the LIPS-A study's secondary outcomes with an increasing soluble Siglec-9 level. The secondary outcomes were the development of acute lung injury, in-hospital mortality to 60 days, developing either acute lung injury or death within 7 days, and ventilator requirement at any time during the hospitalization. In total, we had 255 patients included in this study, with 31 of these patients going on to develop acute lung injury. Looking at demographic differences, a higher proportion of patients without acute lung injury were white, and there were differences in smoking history between the two groups. But besides that, there were no other differences in demographic characteristics or ARDS-related risk factors, looking at the LIPS score. Looking now at soluble Siglec-9 levels, the median soluble Siglec-9 level in the group that went on to develop acute lung injury was higher than the median levels in the group that did not develop acute lung injury. So apart from being associated with just the development of acute lung injury, now looking at the odds ratio of developing the secondary outcomes, we saw a relationship between Siglec-9 levels and all of the LIPS-A study secondary outcomes, including in-hospital mortality, acute lung injury or death within 7 days, as well as very strongly with ventilator requirement at any point. Now, these are odds ratios for every 1 picogram per ml increase in the natural log of soluble cyclic 9. So in conclusion, the serum levels of soluble cyclic 9 are higher in patients who develop lung injury and are associated with both mortality and ventilator requirement, in addition to the acute lung injury and development of ARDS. So soluble cyclic 9 can potentially serve as a diagnostic marker and perhaps even a therapeutic target. We would need larger studies comparing soluble cyclic 9 levels to controls to further elucidate this. And these are my references. Thank you so much. I look forward to your questions.
Hi, my name is Krista Haines from Duke University, and I will be presenting Early Enteral Nutrition Improves Outcomes in Critically Ill and Mechanically Ventilated Patients. This research was funded by Abbott Nutrition, and some of the authors work for Abbott Nutrition out of Columbus, Ohio. Critically ill, mechanically ventilated patients require tailored metabolic support that is often difficult to estimate and has long been debated. The prevalence of malnutrition in this patient population has been reported as high as 78%, associated with poor clinical outcomes. The use of early enteral nutrition has historically been associated with high rates of gastrointestinal intolerance and risks of aspiration pneumonia. However, it is evident that appropriate optimization of protein and caloric needs in these patients can improve outcomes. Given the reported benefits of nutritional optimization and controversy surrounding the optimal time to initiate support, there needs to be a defined optimal trigger point to initiate enteral nutrition. The aim of this study was to compare early enteral nutrition support to late enteral nutrition support in critically ill mechanically ventilated patients. This is a retrospective cohort study that assessed the timing of EN initiation in mechanically ventilated patients from 2018 to 2020. Data from a nationwide administrative financial database, Premier, was utilized to identify adult patients who were started on mechanical ventilation within 2 days after admission. Patients above the age of 17 who received any enteral nutrition support were included. The primary outcome was mortality. Secondary outcomes included hospital, ICU, length of stays, mechanical ventilation days, and total cost. Those who received enteral nutrition were defined by charge codes for enteral nutrition products or tube feeding supplies. We performed inverse probability of treatment to control for confounding variables on observational characteristics. A multivariable logistic regression model was used to analyze the effect of the two enteral nutrition arms on hospital mortality. Linear regression was used for cost analysis, and Cox proportion hazard models were used for days of mechanical ventilation and hospital and ICU length of stay. Our analysis identified a total of 27,887 adult patients with early mechanical ventilation, of which 16,772, 60%, received early enteral nutrition. The mean age was comparable between the groups, 60.1 versus 60.4 years. Regression analysis showed that early enteral nutrition was associated with lower hospital mortality, shorter days on mechanical ventilation, a shorter hospital length of stay, a shorter ICU length of stay, and overall lower costs. Our study's retrospective design has a sizable statistical power with a large sample size, but does have limitations. One of these is the use of ICD billing codes to determine who received nutritional support. The use of coding for our analysis limits access to additional details regarding interruptions of nutrition and also precludes us from knowing dose, frequency, and if additional supplements were used. In conclusion, malnutrition and critical illness, specifically those on mechanical ventilation, is a significant source of morbidity and elevated healthcare costs. The findings in this study provide essential data that the use of early enteral nutrition in this patient population improves mortality, need for ventilator support, and hospital stay, as well as profoundly reducing healthcare associated costs. Implementing an early EN strategy should be considered a viable option for clinicians treating critically ill mechanically ventilated patients. Thank you for your time today, and please email us with any questions.
Perfect. Well, welcome everyone to this oral scientific abstract session of the 2022 SOCCA meeting. I'm Emily Vale. I'm an assistant professor of anesthesiology and critical care at University of Pennsylvania. And I'm joined today by Dr. Mark Lopez.
Hey guys, I'm Mark Lopez at Vanderbilt. I'm also assistant professor. I'm associate program director of the Critical Care Fellowship here as well. And I'm glad to see we have great participation for these interesting abstracts presented today.
You'll note that a lot of our presenters are earlier in their training, so we're excited about what that means for the future of SOCCA research. We'll start by discussing individual abstracts using both the questions from the previous chat as well as things that you add to the Zoom chat here. We're going to first start with student Dr. Tsai, whose abstract integrated single cell and plasma proteomic modeling to predict surgical site complications. She's going to jump off the call in just a few minutes. While you're gathering your questions, we do have one from Tiago Oliveira, who asks, what discussions has your team had regarding future research and dissemination, especially with the exciting prospect of predicting surgical site infections before surgery?
Hi, thank you for the question. Yeah, definitely really exciting to be able to predict this before surgery. And I think one of the really exciting prospects is the realm of prehab and all these things that all these interventions you can provide for patients before they even get surgery. And so the study we're working on right now is a clinical trial on coached prehabilitation for patients in fitness, nutrition, meditation, and cognition. And then we're seeing if their surgical outcomes improve afterwards. And if so, this would be promising, especially if we can identify who would benefit most from these prehabilitation programs.
Can I ask, can you talk a little bit about some of the clinical factors that might be contributing to the observed differences that you saw before surgery in the patients who did not develop both the changes in the markers and surgical site infections?
Yeah, so the clinical parameters before surgery were actually the same. It's the ones that were different were actually intraoperative. So it was I think surgical duration and then intraoperative blood loss were the ones that were different between the two. And so actually, like, yeah, it was a matched study.
Can you just, oh, sorry, go ahead.
No, please.
I was going to say, can you discuss how widely disseminated is this type of technology? Would it be able to upscale to apply to someone having surgery at a community hospital?
Okay, reminder to mute. Thank you.
Yeah, so all we need is actually just one heparin tube and one EDTA tube. So basically like 15 cc's of blood is enough to do the test. The problem is right now, CyTOF is actually quite expensive, and that would really be the limiting factor. If you're going to measure this many parameters using mass cytometry, it would cost around $250 per stimulation. And then we did 7, so that would be quite costly. And then the plasma samples that we sent out were also around $1,000 per sample. And so what we're working on right now is trying to scale down the features that we need to collect, like really looking at which features specifically are predictive and then using those and seeing if we can actually maintain our AUC.
As a follow-up, how long does it take from when the samples are drawn to when you have results back?
It can actually be quite fast. So the samples that we send out to a proteomics lab, those the turnaround is around a week. And then the CyTOF samples, as soon as we collect it, we can basically run it the next day. So we can have results within a day.
Okay. I don't see anything more in the chat. Thank you so much, student Dr. Tsai, and good luck with the match.
Good luck. Thank you.
Let's next move to Dr. Aggarwal, who is a resident at Yale University. His presentation is Association of Diastolic Shock Index and Pulse Pressure Index with mortality in septic shock patients.
And are you here, Dr. Aggarwal? I didn't see your name before. I didn't see if you popped in. I believe he may not be present for this one, so I think may need to move on to the next abstract.
Okay. Our next presenter is student Dr. Rabbin-Birnbaum, whose presentation was electroencephalographic features in the cardiothoracic intensive care unit following intraoperative aminocaproic acid administration.
In the chat from the other platform, William Edwards asked, can you comment on the relationship between dose and neurological complications for tranexamic acid or aminocaproic acid?
Hi, thank you for your question. So the short answer is that our neurological complication that we were looking at is really seizure. So if you mean other things like CVAs, we didn't look at that with respect to dose. And that would be a great thing to do in a future study, especially given the main issues with AF being clots. But the assumption, I think, would be that neurological injury would really be secondary to clot formation, which has been evaluated in many AF studies, and ACA seems to have a pretty good safety profile. We did show a correlation between neurologic injury and ACA, but we need to evaluate, I think, that better. And like we need some more data to see if this is like a real confounder for seizure activity. Though I would expect, I wouldn't really expect a strong relationship between those things given the safety profile of ACA.
Emily, I think you're muted right now.
I apologize. Can you comment on how ACA is used in your cardiac surgical patients? Is it given as a protocol to everyone, or is it at the discretion of the anesthesiologist?
So it is used routinely in a lot of cardiothoracic cases, but I think in the end it is up to the discretion of the anesthesiologist. I have something about this in my notes if you'll let me look at them. Yes, it is at the discretion of the anesthesiologist, but it's given mainly to everyone in cardiothoracic surgery, and especially we prefer ACA over TXA. We did have a shortage of TXA, I think in about 2018, like there was some national shortage of ACA and we did use TXA for a few months, but we prefer ACA over TXA.
So do you think, so I noticed that you noted a trend at least towards EEG seizure and cortical hyperactivity with increasing ACA dose. Do you think that was impacted by duration of surgery, for example, or maybe reflecting the complexity of surgery?
That would be a really interesting thing to look at in future studies. I think we definitely want to get more information on what dosing, how dosing really affected seizure when we have more data, and so we can better analyze that. So we think that right now that perhaps the dose is like dependent on the bolus and the infusion. So longer infusions are more doses, which would increase the amount of ACA that someone is getting. So that would maybe, have something to do with the dose dependent relationship. But no one really has it post-op. So I think that is definitely something to continue to look at in future studies. And also again, with maybe multivariate models, especially looking at confounders like cardiopulmonary bypass, which we did show an association with seizure.
Yeah, I'll add, this would be a great question to answer with an RCT, because you showed that patients getting the ACA in your cohort were fundamentally different, right? Mm-hmm. Their cardiac surgery, et cetera. Exactly. So that would be a strong rationale for it, at least.
Yeah, RCT is our goal.
Oh, please. I'd also like to see what the spectrum of EEG findings that you might expect in these patients independent of ACA treatment, right? What is normal cortical activity? How much variation do we see, or different patterns that may exist when we're monitoring without any clinical suspicion for a problem?
Yeah, that would be a really interesting thing to look into. That's why we are going to get more data and continue with this project.
Great, very nice.
Thank you for your presentation. It's really interesting. Best of luck to you.
Thank you.
I think we can move on to Caywin Zhuang, coming from Carl Illinois College of Medicine, who presented gender and racial representation in anesthesiology. So I'll open it up to the group for any questions, and I'll glance over to the chat and make sure we didn't have any pop in. I guess I have a question to start out if no one else has asked. You mentioned indexing your diversity index to county diversity. Can you talk about functionally how you might do that? And would you be trying to create a single parameter? And what do you think this would add to the findings that you have from this current study?
Right. Thank you for the question. Can you hear me okay?
Mm-hmm.
Okay, so I'm at a match party as well, so there's maybe a little bit of noisy background.
Congratulations.
For my upperclassmen, hopefully me next year. But
yeah, okay.
just to answer your question, the idea is we also have the diversity demographic data from each county. So we do an index of the physician diversity over the county that essentially can create a relative, say a normalized index. So we can compare, say, an urban to a rural community. So that's for your first question. And can you repeat your second question, please?
I guess, what do you think that would add to your current data set? How do you think we could use that functionally to enrich our knowledge on this topic?
Right, so the current data set, I would say that the limitation is a lot of the results are what we would expect, right? In urban settings, we see more diverse physicians. In rural settings, less so. However, it's hard to compare between these different practice settings. So really knowing where we can best invest our resources to increase diversity with a more weighted and fair comparison is the goal for our future next steps.
Very good, thank you.
Can I ask, were you able to match? I can imagine that there's a few different types of concordance or discordance, right? One in which the diversity of the physicians match not just the amount of diversity in the community, but also the representation of different groups within that community, and situations where the groups don't appear similar, but they're both quite diverse. Were you able to differentiate between those two, and how might that affect some of your findings?
Yeah, so just to repeat what I'm hearing, say if there's a predominant, say Asian American or Black American community, that's one type of diversity versus maybe a mismatched kind of diversity in the anesthesiologists. Okay, yeah, so we can get to that granularity.
Okay.
I think that'd be very interesting to see if there's like in terms of the ratio of each demographic, if there's an imbalance. So that'll be a very interesting next step as well.
Well, thank you. I'll open it up again to any questions. If you have one, please add it to the chat, or you can unmute yourself and ask. But otherwise, Caywin, I want to congratulate you on tackling an important topic that we hope to see more work on in the future. So best of luck to you.
Thank you.
I think we'll go ahead and move on to the next speaker for questions. And this is Dr. Fazal from Stanford, who presented soluble Siglet-9 as a biomarker for acute lung injury. And I believe we had a question in the chat. Let me grab, here we go. Yeah, so Ilak Kacha has asked, are you measuring cellular Siglet-9 or soluble Siglet-9?
Hey everybody, Dr. Kacha, thanks for the question. It's an important one, and with our sort of limited 5-minute time for our recorded presentations, there's a little bit that I had to cut out, but we were looking specifically at plasma, so soluble Siglec-9. I know I talked a little bit about the membrane-bound form, and my mentor at Stanford, Dr. Angela Rogers, and one of the sort of field experts on Siglec-9, membrane-bound Siglec-9, Dr. Carolyn Bertuzzi, is also at Stanford, and they actually had a collaboration using our COVID biobank, looking at membrane-bound Siglec-9 in these COVID patients. And the mechanism is a little bit different because, as I was mentioning, soluble Siglec-9, the version that we looked at, shows a pro-inflammatory downstream effect, probably by inhibiting ligand binding to the membrane-bound form. And then I mentioned that the membrane-bound form is a myeloid checkpoint inhibitor, so these glycans, sialic acid glycans, as you know, are found, they're ubiquitous on our body. So they help our immune cells identify itself. So basically it sort of quiesces our natural immune response and leads to sort of the quiet apoptotic cell death, the one that doesn't result in like this milieu of cytokines that leads to a pro-inflammatory state. And so the thought is this other collaboration that I'm talking about with membrane-bound Siglec-9. The thought is if you determine what ligand, if you can create a ligand in the lab or some sort of a drug that interacts with membrane-bound Siglec-9, you can calm down your neutrophils, and neutrophil activation then leads to the cytokine storm that is sort of the hallmark of ARDS. And now we see the opposite. We don't quite know exactly where soluble Siglec-9 comes from, if it's a result of this, this sort of chaotic cell death. Is called netosis, or neutrophil extracellular trap. There's a really good paper on it that I can put in the chat for anybody who's interested. But there's a thought that perhaps the neutrophil going through this cell death pattern, it leads to these transmembrane proteins now being found in the bloodstream, in the plasma, and having a pro-inflammatory effect. The other thought is neutrophil itself causes, like, exocytoses these proteins in a pro-inflammatory state, just exocytoses it out of its cell, and you see these patients have higher levels of both soluble Siglec-9 and perhaps even membrane-bound Siglec-9. Now, we didn't look particularly, I mean, one of the great things that you could do here, probably a logical next step would be to look at levels in these patients and see if there's a correlation between the neutrophil count in these patients and the median soluble Siglec-9 levels that we found. But that's the main difference between the two, and they have two completely different effects.
Can you speak a little bit about the cohort that your study drew from, this clinical trial cohort? What kind of patients were recruited? What were inclusion, exclusion?
Yeah, absolutely. So it was all from the ELIPSE-A study trial, and I believe, so they included patients that I can look through their exclusion criteria. So they included people who were above 18 years of age, who presented to the emergency department and were at high risk of developing lung injury. So they deemed that as a score greater than 4 using their lung injury prediction score. From my graph, I think everybody had a score 5 or above, but there weren't that many differences between the two groups who went on to develop ARDS versus those who did not. And then their main exclusion criteria, because this was a study to see whether aspirin would prevent the future development of ARDS, a lot of their exclusion criteria were patients who would not be able to receive aspirin, those who had a bleeding diathesis or some sort of peptic ulcer disease, for some reason had chronic liver disease or an allergy to aspirin. A lot of them were things like that. Patients who were breastfeeding, pregnant, those kinds of things were exclusion criteria.
Sure. So I would guess not a huge surgical population. Is that accurate?
Yeah, that's pretty accurate.
Okay. Do you know, do things like surgery or big traumas affect Siglec or soluble Siglec-9 levels?
That's an interesting question. I don't know that it's been looked at. I don't know this sort of off the top of my head. We do know that, I mean, oftentimes we see patients with some sort of a left shift after surgery. We see a little bit of a white blood cell count going up. I don't know if off the top of my head, if I can recall seeing a differential and seeing that there was a neutrophilic predominance in any of these patients. We know that there is a little bit of a cytokine storm that comes with the insult of surgery. It's a traumatic experience, but it doesn't, I've never, and we know that surgery is one of the reasons why patients can develop ARDS, but it's not definitely the most common reason that we see. So I don't think that this would be a high yield population. It's an interesting question. I don't know if it would be a high yield population to look at, but it would, if Siglec-9 sort of demonstrate that it is important in these populations, it seems like an important thing to also establish. One of the things that's difficult about Siglec-9 is we don't know what a physiologic, naturally occurring ligand for it is. We don't know what in the human body binds to the membrane-bound Siglec-9. So that's one of the very difficult parts of studying Siglec-9 and developing a laboratory-based ligand and a target for it, because we don't know what exactly the physiologic target for it is.
Okay, and I'm seeing in the chat now, Dr. Shafee has asked or stated, thank you for your great Siglec-9 work. The LIPS-A trial samples are quite old. Do you know stability over time for soluble Siglec-9 when it's stored?
Yeah, that's one of the troubles that we actually encountered early on while we were conducting the study before we moved on to the, well, one of the things is there aren't many people doing work on soluble Siglec-9. So the assay itself, getting that sort of validated took a little bit of time. We've gone through a few different manufacturers of our reagents and our plates, and eventually to take away more user variability, we went on to develop this, or to use a fully automated ELISA system. But we were finding that the longer they were stored, the more times that we thawed, these cycles of thawing and refreezing, that there was maybe a little bit of discrepancy in some of our samples. This is all anecdotal. I have not like looked at it in particular. We have run samples again when numbers did not make sense when we were running them manually, sometimes chalking it up to user error or user variability. Eventually, for the study's purpose, we had just one person do everything, and then we kind of just use that. But there is a thought that these proteins denature with multiple freeze and thaw cycles in a -80-degree freezer.
Yeah, good. It's an important consideration for biomarker work like that.
Absolutely.
Okay, I don't think I see any other questions. So thank you, Dr. Fazal, great presentation. And,
yeah, thank you guys.
Thank you for answering all these questions. Unless our first presenter has joined us, we have one. Nutrition improves outcomes in critically or mechanically ventilated patients. That's Dr. Haines et al. Presenting. So I believe I saw a question for this at the top of the chat. Give me just a moment. Here we go from Rebecca Aslickson. Question. The last speaker with a nutrition study. Thank you for this interesting talk on an important topic. You have a cross-sectional study that can show associations, not causation. You've shown significant associations between early enteral nutrition and multiple positive ICU outcomes. Yet there is significant conflation here. Patients who are doing better will tolerate enteral nutrition and vice versa. These data cannot support causation, i.e. one causing the other. Can you comment some more on this?
I'm wondering if Dr. Haines is on the call.
I think this author may not be as well. Dr. Haines, if you're on there, will you speak so we can know?
Well, this is Rebecca Aslickson. I don't see that she's on here, but I think this is an important point for learners to bring up because these enteral nutrition studies are important. These are data that we've seen. We've seen these across multiple other studies. And it's great. We need to think about this. This is important, but there's a lot of conflators here. And these kinds of studies can show associations, but they don't necessarily show causation. You would need cohort studies and temporal longitudinal studies if you want to get at causation.
Absolutely agree. The one question I had written down when I was reviewing the abstract was, are patients fed within 2 days as sick as those not being fed within 2 days? Things like high dose vasopressors, et cetera, can limit what's going on with patients who aren't being fed early on.
Yeah, and this is, I mean, these are data, we've seen this in other studies and such. And I mean, I welcome other folks' thoughts because I think this is a really important topic. Nutrition's very important for our critically ill patients, but they have to be able to tolerate nutrition. And if they are severely ill, they don't tolerate nutrition. And so it's all conflated, it's all conflated.
Yeah, no, thank you, Dr. Esselstyn. It's such an important point. And sometimes we'll use the term confounding by indication to describe this problem, right? That there are unmeasured, subtle, but real clinical differences in the patients that clinicians make these decisions to deliver the therapy to a patient that aren't recorded in the data set, that aren't reflected in, and some of the other things that are measured and adjusted for. Premier itself is a very, very detailed data set with lots of important information, but it doesn't have a severity of illness marker. So you can't account for things like SOFA scores that might help you get closer to the problem. But certainly, even with things like SOFA scores, there can be residual confounding that isn't addressed here. So thank you.
No, completely agree. And that does help to get at some of the confounding, but it's a very complex system. And if you're not measuring a confounder, you can't control for it, you can't account for it.
One of Jack Washna is a health services researcher and intensivist at University of Michigan, and he says that his kids think it's so funny that he studies how if sick people do worse in the hospital, like if being sick makes you die, which is, you know, in some ways, like we have to come back to that idea that are they sicker patients, and we all know the people that we withhold the nutrition on are different in other ways. I also see a comment.
I was going to say, how come I'm not surprised that Ted's kids are also asking smart questions?
I think that makes a lot of sense. I do see a comment here from Tiago Oliveira. His understanding is also that he'd have to understand the literature source, but the data suggested that holding with nutrition in the first 2 to 3 days of critical illness may actually be associated with improved outcomes. And that's absolutely right. That comes from some trial evidence that if you can randomize people to this therapy, some early withholding during that period of acute illness may not be harmful.
I see Dr. Fazal has shared a link to membrane-bound cyclic 9 agonism in COVID samples, so feel free to glance at that reference if interested. I think if we don't have any additional questions for our speakers, however, we can go ahead and end the session just a couple minutes early.
Great. Well, thank you to the speakers. Thank you to all of our participants. It's been a really nice session, a nice way to connect with some of the future stars in SOCCA research.
Thank you, everyone.